Namaste. Good morning. So welcome again. Welcome again in day two. As we all know that we started last day almost similar time, and now we are on the day two. Day one was very successful in my eyes, so I'm feeling bit excited. So without any further delay, let's just start the today's academic journey because last day we experienced that some such kind of delays many times, and that most of the time causes delay for the next sessions. So in this session, we have six papers. Dr. Sunila Rathi, Satyajit Barik, Swati Kumari, Sabab Ahmed, Geetu P. Ranjan, and Malavika Das. And for chairing this free paper session, we have two esteemed faculties with us. One is Dr. Naren Kumar Singh. Sir has completed his MPhil in Psychiatric Social Work from Central Institute of Psychiatry, then PhD in Psychiatric Social Work from Ranchi Institute of Neuropsychiatry, and he has almost 4 dozen of publications in his credit. Currently, Naren sir is serving as Senior Psychiatric Social Worker in Central Institute of Psychiatry. Another chairperson for today is Bhupendra Singh. He completed his MPhil in Psychiatric Social Work from Ranchi Institute of Neuropsychiatry, then served to Dr. Ram Manohar Lohia Hospital as assistant professor. And now again in another place, he is serving as assistant professor in Department of Psychiatric Social Work at Maharashtra Institute of Mental Health. So over to both the chairpersons. Thank you.
Thank you, Dr. Bhupendra. I am audible.
Yes, sir. Yes, sir.
So, good morning to all of you. First of all, I would like to give my sincere thanks to giving me this opportunity to chair this session. I hope everybody has taken their breakfast and tea with this. The session we are going to chair the subheading mental health seeking and treatment experiences. If you see the seeking help for mental health issues and receiving appropriate treatment are essential for overall well-being. However, many individuals are hesitated to access mental health services, particularly in institutional settings like mental hospitals and tertiary care center. This related is often driven to fear of stigma, discrimination, and social exclusion. However, if you see the literature, it is very evident that individual who has seeking treatment frequently they are encountered by negative experiences, including being labeled, judged, and marginalized by their healthcare provider as their community member of community. So these factors contribute to the cycle of silence and suffering where the mental health need remains unmet and condition may worsen over a time. So, to reducing the stigma and promoting compassionate community mental health care are vital, encouraging healthcare behavior and motivating treatment outcome. So the all the six paper is related, which will be enriching our knowledge. Discussion will be very informative and increase the positive healthcare seeking and patient also. So with this we
Good morning, sir.
Bhupendra, we lost the connection. Can you lead now?
Yes, sir. Very good morning to all of you. Naren sir was very right because the help seeking and treatment experience will impact and we reduce the treatment gap, which is a current ratio for the treatment procedure, treatment gap in all these things. So, in the continuation of, in the absence of Naren sir, I would like to continue with the presentation and I want to invite Sunila ma'am to start their presentation without further delay. Sir will join maybe.
Sir is here.
Yes.
Is it visible?
It was visible, but you opted another option. Yes, now it is.
Good
Yes.
morning to all. Today I am going to present on opioid misuse among women in urban area, a 10-year retrospective study. Opioid misuse among urban women has emerged as a critical public health issue with distinct epidemiological patterns, socio-cultural determinants, and healthcare challenges. Research indicates that women are particularly vulnerable to faster progression from initial opioid use to dependence compared to their male counterpart, often due to their certain biological, psychological, and social factors. National Survey on Extent and Pattern of Substance Use in India in 2019 suggests that the prevalence of current opioid use is found among women is 0.2%. A rapid assessment survey conducted among women drug users in India found that 36% of the current users were using a prescription opioids. Women in urban setting face unique barriers to treatment access, including heightened stigma, childcare responsibilities, and lack of gender sensitive treatment program. Therefore, it is important to study and pay attention to the issue of women opioid misuse in India. The present study aimed to study the social, demographic, and clinical profile of women seeking de-addiction treatment at tertiary care center in North India. The present study is a retrospective chart review from the State Drug Dependence Treatment Center Institute of Mental Health. A case record of female patient from January 2015 to December 2024 were reviewed retrospectively to study their social, demographic, and clinical profile. During this period, around 15,113 patients sought consultation, of whom 1.3% were women, with 37.8 specifically reported opioid use, and out of these patients who were taking opioids, 44.6 from urban areas. So the information was gathered using a semi-structured performa and detailed case records. All the patients were evaluated by the postgraduate trainees and psychiatric residents under the supervision of consultants in the center. This table is showing the social demographic profile of the patient, and regarding their age group, it was found that most of the patients were belong to 21 to 30 years of age group, that were 57.6%, and the mean age was 31 years. And regarding their employment status, 42.4 were homemaker and 39.4 were employed. They were employed as self-employed or part-time employed, or full-time employment. And regarding their living arrangement, more than half of the patients were from nuclear family, and most of the patients were married. Regarding their education, 42.4% of the patient up to middle and 24.2 were higher secondary, and 15.2% of graduate and above. Regarding their clinical profile, it was found that around 63% of the females were referred from other different clinics like psychiatry OPD, medicine OPD, surgery, gynae. So they were referred for taking de-addiction treatment from the different special clinics. and only 36.3% of the women reported by their self. Sorry, most of the patients were accompanied by their family, their relatives, husband, parents, and friends, and only 30.3% were reported alone. And regarding their family history of substance use, 63.6% of the females having family positive family history of substance use in their parents, in their husband, or in their grandparents. So this figure is showing the type of opioid use among these patients. Heroin, 12 patients were taking heroin, 11 were taking tramadol, 5 14-phenargan injection, 3 were using morphine, and 1 was taking opium, and 2 were spasmoproxyvol capsule. So the route of administration of opioids, this finding is showing that more than half, 64% of the patient were taking opioid through IV route, and those who were taking through IV route, more than half of the patients were history of sharing of needle and syringes. So this clearly showing the high risk behavior among these opioid user patients. And 21.2% of the patients were chasing opioids. Regarding the reason of initiation of opioid use, it was found that more than 40% of the patients were started due to certain physical or psychological problems, like menstrual cramps, body pain, headache, pain during gestation, stone pain, or low mood, loss of their family member, sleep related issues. So they were started due to all the physical and psychological problems. And 11.6% of the patients were started with their friend groups, and 4.7% of the patient to accompany their husband, because their husband was already taking opioid, so they started with their husband. And 6.2% of the females started due to curiosity. So regarding their comorbid physical and psychiatric illness among women, it was found that the physical medical illness is quite high among them. That was 33.3%, and hypothyroidism, asthma, stone, and 4 patients were hepatitis C positive, and 1 was HIV positive. And regarding comorbid psychiatric illness, it was found among the 21.2% of the females, like mood disorder, psychotic disorder, somatoform disorder, and personality disorder. So, regarding the treatment related behavior, it was found that 78.8 most of the patients were taking treatment through OPD, and only 21.2% were admitted for taking the treatment. And regarding their follow-up, most of the patients having no follow-up, that was 69.7%, and only 6.1% of the female having 5 and more follow-up, and 24.2% having 1 to 5 visits of follow-up. Regarding the previous treatment, 18.1% of the patient having history of previous treatment for the opioid use. So, conclusion, the majority of women were aged between 21 and 30 years with a mean age of 31. Common opioid misused, including tramadol, heroin, and initiation of use was primarily influenced by pain management needs and familial exposure. High rates of comorbid psychiatric disorder and medical illness were found among women with opioid use. The follow-up and outcome were generally poor. It is therefore important to evolve alternate strategies to identify women with problems related to drug abuse in order to understand its impact, both from the individual as well as from the gender perspective. Addressing opioid misuse among urban women require a multifaceted approach that considers gender-specific vulnerabilities, reduce systematic barriers, and implements tailored interventions. This study underscores that opioid misuse among urban women often originate from prescription misuse and familial influences with a significant delay in seeking treatment. These findings highlight the need of gender-sensitive prevention strategies and early intervention measures to address opioid misuse in the population. Thank you.
Thank you, Dr. You have
Thank
finished
you, sir.
your presentation within the time. and it was very nice presentation and very informative. Uh, any question, any clarification? The paper is open for question, comments, clarification. If anyone wants any clarification, any query regarding this paper,
Naren sir, something
your
network
comment
issue at your end.
query
Hello,
is most welcome.
Naren sir, you are not clearly audible.
There
Naren
is
sir,
a
you are not
request by
audible
Dr.
properly.
Sadab Ahmad for early presentation.
Now,
Sir,
now I am audible.
Yes, sir. Yes, sir. Now you are audible perfectly.
Please check the chat. Dr. Narendra, Dr. Sadab Ahmad has requested for early presentation.
Yes, yes, I have seen that, sir. I have seen his request. So, any clarification, any question regarding this paper?
sir,
Anyone wants any?
I have one doubt. I
Yes,
want to
please,
ask something.
please go
Uh,
ahead.
Dr. Sunila ma'am, your presentation is very nice and very informative. But just might be many people says open. Huh, okay, I'm audible.
Yes,
Am I
go ahead.
audible? Ha
Yes,
ha.
yes.
So the presentation is very nice and very informative. But just I want to ask, what are the future implications of this study?
The future implication of this study is that we found that most of the females were referred from the different clinics because they do not consider that they are having substance dependence related problem. So the knowledge among these females were very poor. And second is stigma is very high because when we are interviewed these patients, when we were taking the history of the patient, they were hiding certain facts because according to them that everybody labeled them that they are substance dependence or wo nasha karti hai, so that's why they are hiding. So it is very important that we can generate certain awareness activities among these females because most of the females were started prescription opioid use due to their pain management. So they don't have any idea regarding that this can lead them in dependence pattern.
Okay, fine, fine. Thank you.
Anyone else? If there is no question regarding this paper, then I request to co-chairperson Bhupendra, please introduce the second topic. And Dr. Sabam Ahmad is requested to can we allow him to present early?
Yes, sir. We can allow definitely if he has some issues because he text.
So present, please introduce his name and
So,
topic.
so I just request to Satyajit and Swati, please wait a while, and after the Sada presentation, you will be present.
Thank you, Chair,
Okay,
and
sir.
thank you, Inderji. It's my real privilege that turned out to present early, and I will be highly inducted to that. So, since I am traveling, you can see I'm in train. So, shall I share my Word documents if you allow me?
Please.
So, um, once again, very good morning to all of you. So, my topic of the presentation is relapse prevention techniques, few illustrations from the fieldwork. Okay, as you know that field is
Dr.
very important.
Sadab, are you sharing some screen or
I'm sharing my research paper, and
actually it is not
it's
visible?
open.
That's why I asked.
Oh, it's not visible.
No.
Okay,
Yeah, your screen is not visible. Please share your screen.
once again, I will do this. Just since I was sharing the screen and I was to download it once again. And sir, is it down? Is it showing now?
Not yet.
It is not visible.
Yes, I'm presenting to my file. I have to save it in my doc file. Because
So Naren sir, can we go without the PPT, without the slide presentation?
Yeah. If there is
can we?
issue, then we can go for
Okay,
without.
okay, okay.
Okay.
Thank you, sir.
Please
Thanks
share
for
your methodology and finding
okay,
and
okay, okay.
conclusion, please.
Okay, a brief introduction, sir. This paper tries to cover out the leakage, highlight the technique and the relapse prevention technique, helping the drug addicts to prevent from taking the drugs. It's basically the critical and crucial and critical time for the drug addicts that what they can do to stop drugs. And social workers as a change agent should have some techniques to prevent the abuser from taking the drug. This paper includes some of the feedback from those drug addicts who successfully left the drug. So we all know that relapse prevention technique is a self-control program designed to teach individuals who are trying to change their behavior now how to anticipate and cope with the problems of relapse. In a layman terms, relapse known as a person failed to able to change any desired behavior based on the principle of social learning theories and of those will be discussing if somebody wants my paper then we'll do that. Okay, and we'll be skipping that all those what the drug means, what are the abuse and all those social work, rules. But basically, we are dealing with the what I will be saying here, the role of social worker and their what are the techniques that they adapted for the relapse prevention. So in case that they worked as a counselor, they worked as a motivator, they worked as a drug user, and they work as a as a family counselor in which they meet with the family members to train, provide guidance. Also, some of the clients. So my objective was main objective was what are the methods adopted by the drug users to prevent from relapse, to understand the problems and other there were other objectives there as well, but I'm skipping those and coming um, to the part of the research method as I was asked. So the research design, researcher wants to describe the condition of a drug user in abstinence from the drug and the relapse prevention methods and adapted the drug user to involve in a qualitative research method that collect its primary method from Shala and their nearby villages. Researchers collected the data on field discussion with the expert users and users a semi-structured interview schedule and got replies from the sample design was it was a perspective and some snowball as well because the peer educators getting information from the peer educators and who are the drug addicts and who are in the process of recovery and those who are already on the so convenience sampling obtained by selecting convenient population being investigated which is selected neither by the probability nor by the judgment. Sample size was altogether 40 by Dhansala because Punjab got blanket ban of drugs. Most of the drug imports and all those started. You know, the, there was a substantial evidences that the numbers of tickets are increased in Dharamshala, which is very close to the Pathankot, the bordering area of Punjab. So here the there are few limitation of the studies, but some of the case studies that I wanted to refer here is Manjeet's name all as confidential to change the name of the Manjeet. And he was a very intelligent student, and we had a detailed case study of him and his situational. Then we did a case study that we call situational analysis, problem analysis, and then descriptive analysis and the possible solution of it. So in situational analysis, the Manjit, the drug who start taking alcohol and smoking at the age of 7th class when he was a boy in senior secondary school due to the influence of the peer group. So there are various sorry for the inconvenience. Am I audible? So
Yes, yes.
according to the peer pressure, he started his so I'm speaking lots of things that call करते हैं किसी का call है ना फोन में I'm getting second call from home telling me not to call. Yes. मेरा मोबाइल
Hello,
so
Dr.
yeah
Sabab, your
yeah
voice is not
yeah
clear, please.
yeah I'm getting frequent calls so I have to disconnect that sorry for the interruption. So there are various respondent and all. I'm coming directly to the various mm, uh, my statistical data which I could share is to the uh, uh, um, there are various questions that we structured questions that I have asked. What I was just they were
Dr. Sadab, you please conclude your study because we have less time.
uh, hello, am I audible?
Yes, yes, yes,
Uh-huh.
yes.
So
We are going behind the
um,
schedule. Please conclude your
yes, sir.
presentation.
So
Yes.
so there were various such cases where as Majid, we have taken into account of that, and mm, uh, so there are uh, uh, two cases that I want to discuss in this research, but the circumstances in which they have taken they started taking drugs, where of course we all know that peer pressures and mm, connecting. But in the case of Manjit, in which we had taken the data, in which we have tried to analyze the situation and what are the interest area where when the impulses are being, high and giving more MET and uh, you know, relapse prevention techniques in those cases especially in this case, where he was ex sports person and analyzing the situation where he can, going for the play and whatever the situations. Some of the cases where the religious person who are more inclined to their religious rituals, they are being motivated to uh, uh, you know, doing those things and then meditation of yoga and sports and other books and some are involved with the singing art, use of some other direction, how to keep them busy. Yeah. So these were some of the techniques that social worker adapted so that after analyzing their whole case studies like Manji, and then they for interviews or given like some of the they had selected who are the other family members or the friends or even include their girlfriends and this and if some people who help them reducing
Okay, okay, Dr.
analyzing
Sampath.
their actual conditions of depression and loneliness, depression and aggression, fatigues and weakness. So they were given proper intervention. Yeah, the finding
Okay,
which
okay,
is
Dr. Sadab, we finished our timeline because we don't have much time. I'm extremely sorry. Eh, Okay, so Naren sir.
Okay, thank you. It was a very nice presentation. Some differences and some
Please.
problem are running because is traveling. So due to this problems, we are not able to hear properly him. But whatever we have learned, we have hear from him. It was very informative and very useful for those who are working in de-addiction centers. So for that, social work professional, those who are working in de-addiction center, the findings and the techniques, who whatever he has shared, it will be very beneficial for us. So coming to the next presentation, I think we are running behind the schedules. So I would
Yes,
like
sir.
to
Yes.
invite Satyajit Bhare, his topic on an assessment of patient satisfaction in psychiatric tertiary care hospitals. So, over to you, Satyajit Bari. Please start your presentation.
Am I audible, sir?
Yes, yes.
Yes.
So, good afternoon, everyone. I am Satyajit Varik, MPhil Psychiatric Social Work Training from Mental Health Institute, Cuttack. My topic is an assessment of patient satisfaction in a psychiatric tertiary care hospital. Patient satisfaction has emerged as a pivotal indicator of healthcare quality and organizational professionals' performance. In modern health system, patient satisfaction is playing an increasingly important role in quality of care, reforms, and healthcare delivery. It reflects not only the patient's perception of the care they receive, but also serves as a benchmark for evaluating the effectiveness, efficiency, and responsiveness of healthcare services, particularly in inpatient departments where patients often interact extensively with healthcare personnel and experience the full spectrum of service offered. Rationale of the study: patient satisfaction in psychiatric care remains an underexplored yet critical indicator of healthcare quality, particularly in tertiary care setting. Psychiatric patients often face unique challenges including stigma, communication barrier, and complex treatment regimens, which can significantly influence their perceptions and satisfaction with care. This study seeks to fill this gap by assessing the level and determinants of patient satisfaction in a psychiatric tertiary care hospital. These are the review of literature. Aim of the study: to assess the level of patient satisfaction among patients admitted to inpatient department of a tertiary care hospital. Objective of the study: to evaluate the overall satisfaction level of patient admitted in the inpatient department. To identify the association among demographic factor and patient satisfaction level. Hypothesis: there will be no statistically significant level of satisfaction of the patients of the tertiary care hospital. There will be no significant association among demographic factors and patient satisfaction levels. This study has adopted a descriptive research design, and the present study was carried out at the IPD Inpatient Department of Mental Health Institute, Center of Excellence, SCBMCH, Cuttack, Odisha. Sampling technique: sample random sampling technique was used. Sample size for the study is 50. Tools used: socio-demographic data sheet, that is the socio-demographic information collected from each participant, including their age, gender, marital status, socio-economic status, education, etc. Client satisfaction questionnaire, Larson et al., to assess the client satisfaction with the service received in a healthcare setting, especially in mental health and counseling context. The CSQ 18 consists of 8 items and each item is rated on a 4-point Likert scale. Inclusion criteria: age 18 to 15, both male and female, willingness to participate in the study, studied up to matriculation, patient admitted in the MHI. Exclusion criteria: chronic comorbid physical and neurological illness, person diagnosed with IDD or any substance related disorder. Ethical consideration: informed consent, ensuring all participants understand the study's purpose, procedure, benefit, confidentiality, and voluntarily agree to participate. Approval obtained from Departmental Research Committee and Institutional Ethics Committee of the institution. Procedure: the study was conducted in the MHI COVSB Medical College Hospital, Cuttack. The researcher has taken approval from BRC and IEC prior to conduct the study. The data sheet for the socio-demographic was structured by the researcher. The simple random sampling method was used to collect the data according to inclusion and exclusion criteria. The written consent has taken from individual participation by explaining the nature purpose of the study, and data has collected through assessment tools. The collected data was entered into a statistical package for analysis. Here is the result and discussion. Out of the total 50 participants, the most of highest number of participants was from male. The percentage is 56. And as per the religion is concerned, 84%, that is 42 number of 84% of the participant was from Hindu, and 32% from OBC. Patient satisfaction result as per the CSQ 18. The mostly satisfied 31 number of participants, that is 62% participant were mostly satisfied, and 22%, that is 11 number of participant was mildly satisfied, and 16% of participant, that is 8 number of participant dissatisfied. Satisfaction and socioeconomic status. To simplify analysis, socioeconomic status group were contained into three categories: lower socioeconomic status, merging with lower and upper lower, that represent the 20 participant. Middle socioeconomic status, lower middle, that is 18 participant. Higher socioeconomic status, comprising of upper middle and upper, that is 12 participants. There is a statistical significant association between socioeconomic status and satisfactions. That is, patients from higher socioeconomic status group reported with higher satisfaction level. That is the association analysis. Except socioeconomic status, none other sociodemographic variables are associated with patient satisfactions. Limitation and application. The study was conducted in a single psychiatric tertiary care hospital with limited sample size and limited time period, which may limit the generalizability of the findings. Future research should consider longitudinal assessment and incorporate feedback from caregivers and family members to develop a more holistic understanding of satisfaction and its determinants. Addressing both clinical and non-clinical aspects of care will be key in delivering more responsive, effective, and human psychiatric services. Future research should be conducted across multiple psychiatric facilities to compare satisfaction level and understand regional or institutional variations. Conclusion. Overall, the result underscore the importance of strengthening patient-centered care approach within psychiatric tertiary care center, enhancing collaborative decision-making, improving wait time, and refining hospital infrastructure could lead to improved satisfaction and potentially better clinical outcome. The study suggests the need for continuous quality improvement initiatives focusing on enhancing patient engagement, streamlining administrative process, and upgrading the facility infrastructure. A more patient-centered approach integrating patient feedback into services design and delivery can contribute significantly to improve satisfaction and care outcome in psychiatric setting. These are my references. Thank you.
Thank you, Satyajit. You have presented within the time, and the methodology was very sound, and others, whatever slides share, and it was very informative and very useful for us. So with this, the paper is open for clarification, question, comments.
Satyajit,
Yes, sir.
wonderful presentation. I must say that
Thank
you work hard.
Thank
Good.
you. Thank you, sir.
If no one have questions, so I have one clarification only.
Yes, sir.
Satyajit, to why you not present some similar studies in your discussion part?
Sir, similar study in Indian context, there is no similar studies I have found. One study I have found that is a comparative study, that is controlled, randomized controlled trial, that was that the interprofessional collaboration they have provided with some mental health professional regarding the interprofessional collaboration, and this team will treated the patients, and another was there will be no training to the mental health professional, and they will be treated some number of patients. There is a comparison between these teams as per their client satisfaction questionnaire, and they check the patient satisfaction. And I have mentioned it in my review of literature, and I am
That
not
is
unable
okay. I
to.
understand you mentioned in review, but I just want to in why you not
Yes,
mentioned it. That is okay. Thank you.
yes, yes. I will look into it. Thank you.
Anyone else? So I have one question, Satyajit.
Yes, sir.
How,
Yes,
how, how you can defend your findings, because you have presented high socioeconomic status. Those who are belong from high socioeconomic status, they perceive
yes,
good satisfaction.
yes,
So how you can defend yourself? What are the impact of psychiatric illness? Because I am belong from higher socioeconomic, that's why
yes,
I perceive good satisfaction.
yes.
So there is no relationship of psychiatric illness. So how you can justify your findings?
Yes,
Whether it is related to economic status. If I am
yes,
having some mental illness, I belong to higher socioeconomic, then I perceive good satisfaction. But
sir.
what are the implication of psychiatric disorder? What are the, there are so many psychiatric illness like schizophrenia, psychosis. They perceive unsatisfaction their lives.
Yes,
So how you can differentiate yourself?
sir. Sir, as for the mental illness is concerned, there is no link with socioeconomic status and mental illness. But as for the satisfaction is concerned, so the satisfaction, not merely the mention about that they they given their opinion as per the treatment they received, and as per the experiences they feel during their hospitalizations. So as per the socioeconomic status is concerned, sir, there is a there is, that means in Odisha they have the free facility in the hospitalization, free consultation, and free medications. But sir, the transportation cost and the caregiver in Odisha, we provide free. The government provided free food and free medication to the patients, not to the caregiver. So yeah, and to accompany a patient, the caregiver resides in the ward or outside, has to spend a lot of money for the illness of their relatives. And as per the socioeconomic condition, socioeconomic status is concerned, it's not only concerned about the economic status, it's concerned about their occupation and their education. Sir. The socioeconomic status is somehow connected with their educational status. That means they know that what are the outcomes of the illnesses, and what will be the treatment modality, and what will be the future implications of their illnesses, and how can they seek the treatment procedures. And as per the socioeconomic status, lower or middle, that's a focus on socioeconomic skills, that not only the economic condition but the education and occupation are also a part of the socioeconomic status, sir. And sir, as this study contains only 50 samples, I think that there might be a biasness, that higher socioeconomic status have the higher satisfaction. When the study will be with a multi-center, and the study will be with more sample size, so that there can be a sir there can be a generalization of socioeconomic status, and patient satisfaction can be sir association can be sir identified, sir.
Okay, thank you. Thank you.
Thank you, sir. Thank you, sir.
Sir,
Hand over to Bhupendra for further proceed.
Satyajit, just I want to know that what is the prevalence rate of intellectual disability in Odisha?
Uh,
Have you gone
in
through it? In which
no sir,
number
no,
is the Odisha state is available?
no sir,
Okay,
no
this is
sir.
in
Currently, I
second,
have.
na, according to 2011
Ha ha
survey.
ha. Yes,
This is on second number. So
yes, yes.
No need if you studied in your center only, so you will get
Sir,
maximum data and maximum the feasibility and
sir,
result.
sure, sir. I will look into it. Thank you, sir.
And don't use AI in your and
Sir,
paraphrase, please.
sir,
Got it?
sir.
Okay, thank you.
Thank you. Thank you.
Naren sir, now we call for next presentee.
Yes. Please call her.
Yes, Swati. Miss Swati, please.
Sir, is it visible?
Yes, please go ahead.
Okay. Good morning, everyone. So, myself Swati, and currently I'm working as a psychiatric social work in Ibhas, Delhi, and also I'm pursuing PhD from the Department of Psychiatric Social Work at Trent. And I would express my thanks to ISPSW to give me this platform for presenting my study on the efficacy of a brief psychoeducation module on stress and coping among caregivers of children with intellectual disability. We'll start with the introduction. The birth of a child with intellectual disability can disrupt family expectations, impose significant burdens on caregivers, leading to poor psychological well being. Intellectual disability, previously referred to as mental retardation, is a condition characterized by significant limitations in intellectual functioning and adaptive behavior, often presenting before the age of 18. Psychoeducation has emerged as a promising intervention to support caregivers in managing these challenges. Psychoeducation as a systematic, didactic approach to provide patients and their families with information about the illness and its management, facilitating understanding and
Your
coping.
slides are not moving, Swati.
Okay, 1 second, sir. It now it seems, sir, moving. It can be empowered caregivers and enhance their ability to navigate the challenges associated with intellectual disability. This is the objective of this study, to assess the efficacy of a brief psychoeducation module on stress and coping in caregivers of children with intellectual disability. So this is the methodology. This study was conducted at Ranchi Institute of Neuropsychiatric and Allied Sciences, Penpas, in Kaki, Ranchi. A pre-test, post-test design was employed with an experimental group receiving both treatment as usual and 10 sessions of psychoeducation conducted over 10 weeks, and a control group receiving only treatment as usual. A total of 20 caregivers of children with intellectual disability were recruited for this study on the basis of purposive sampling techniques and equally divided into the experimental and control group. Assessments were carried out at the 3 time points: baseline, immediately after the intervention, that is post-intervention, and at a 3 months follow-up, using the family interview for stress and coping in mental retardation. So this is the inclusion criteria for the caregivers of children with intellectual disability. Caregivers of children who diagnosed with intellectual disability as per ICD-10 DCR, and the category was moderate and severe level. The age range of the children is 6 to 10 years. Intellectual disability children of either sex. Caregivers actively involved and living in the same house for more than 2 years. The age range of the caregivers between 25 to 40 years, and caregivers who have given the written consent. The module of the brief psychoeducation. The brief psychoeducation module is tailored for caregivers of children with intellectual disabilities. Participants engaged in 10 sessions held at Renpa Sakir, each lasting 45 minutes to 1 hour. Duration of the initial session The focus is on program orientation and establishing a therapeutic relationship between the caregivers and facilitators. Subsequent sessions delve into specific topics, beginning with an assessment of knowledge and dispelling myths surrounding intellectual disabilities. Awareness of the disorders is then addressed in the third session, followed by discussion on treatment availability in the fourth session. The fifth and sixth session explore the critical uh, the fifth and sixth session were explored the critical role of caregivers in the management of intellectual disability. In the seventh session, caregivers are informed about available schemes and provisions to support their caregiving responsibilities. The eighth session is dedicated to stress management techniques tailored to the unique challenges faced by the caregiver. The ninth session focuses on problem-solving strategies to address common issues encountered in caregiving. Finally, the 10th session involves termination and feedback, allowing caregivers to reflect on their journey and provide inputs for future program improvement. So this is the table 1. Table 1 presents a comparison of the socio-demographic variables between caregivers of children with intellectual disability in both the experimental and control group. Regarding religion, the majority of the individuals in both groups identify as Hindu, with 80% in the experimental group and 90% in the control group. Islam is represented by 10% in the control group, while 20% of the experimental group follows the Sarna religion. None of the individuals falls under the general category, while the OBC category is prominent in the experimental group compared to control group. So individuals represent scheduled tribes 30% in the experimental group and 20% in the control group. In terms of mother's age at marriage, the most common age range for marriage is 90 to 20 years in both the groups. Most deliveries occurs between the age of 23 to 30 during delivery, with 50% in the experimental and 30% in the control group. Marriages in both groups are non-consanguineous, and the distribution of normal versus cesarean deliveries is equal in both, with 40% each. All mothers in both groups are housewives. The father occupation varies across, including daily wages, self-employed, private job, government job, and their income falls under 20,000 to 30,000 in both the groups. This is table 1.1. This compares the socio-demographic variables of children in an experimental and a control group. The mean of the age of the children in experimental group is 8.6 years, while in the control group is 7.4 years. Both groups have an equal representation of male and female. The experimental group has a slightly higher proportion of severe cases of disability. However, the chi-square test shows no statistically significant difference between both the groups of age, gender, and disability detection. This is the pre-intervention phase. So this slide presents the assessment results taken before the psychoeducation session began. Both the experimental group and control group were assessed by using the FISC-MR scale, which measures the stress and coping in the caregiver. The result showed that there were no major differences between both the groups at the start, which means both the group have similar level of stress and coping abilities, which is important to make sure that the any changes later are due to the intervention. This is the post-intervention assessment. This slide shows the result after the psychoeducation sessions were completed for the experimental group. The caregivers in the experimental group showed significant improvements in the different areas. There were better.
Bhakti, you conclude your study.
Okay, sir. So the key findings, the baseline comparison highlights that caregivers from both the groups were similar affected in terms of stress and coping, suggesting homogeneity at the start of the intervention. In this study, caregivers showed significant improvement in all the domains of the family interview for stress and coping scale after the psychoeducation intervention. These domains include daily care, family emotional stress, social life awareness, expectations and attitudes, child rearing practices, and social support. At the follow-up assessment, the experimental group showed significant improvement in the subdomain of effect on siblings and other family members, while the other domains maintain the changes observed at the post-assessment on this rule. So the conclusion part is a psychoeducation intervention offered valuable support to caregivers of children with intellectual disability, leading to enhanced coping strategies and reduced stress. The result emphasizes the significance of incorporating psychoeducation program into comprehensive support system for caregivers to manage the challenges that come with caregivers' responsibility. Thank you.
Hello? Hello?
Yes, sir.
Yes, sir, you are audible.
Swati, you have finished your presentation?
Yes, sir.
Yes. So the topic is open for discussion, clarification, question. Question to her.
Swati?
Yes, sir.
Yeah, I
Yes.
just want to know your tool, what module you use. This is self-developed module or you use to someone else's module?
Sir, I have
Sir,
developed this module by self, sir, with the help of uh, some research. Taken help from the research, sir.
have you checked the
On the basis of review literature and research, sir, I have developed this model. Collecting assessment of the caregivers, whatever they are facing the problem. So I have developed all these models from that point of view.
Narendra sir, you are not audible. Narendra sir, your voice is
Okay,
breaking.
running.
Sir, not getting your voice, sir.
Please go for another presenter. Bhupendra, please proceed further.
Geetu Ranjan, are you there?
Yes, sir. Yes,
Yes, yes. Please continue your presentation.
Good
Go to
morning,
the
all.
present mode.
Hello.
Yes.
Am
Continue.
I audible, sir?
Yes, you are audible. Just I am saying you just put your pin to your PPT will go to the presentation mode.
No. I have already put it in the presentation mode, sir.
Okay, you please continue. The same issue is also in with you. Please continue.
Good morning, all. Myself, Geetu Pirajan. I'm an IFL scholar at CIP Ranji. I'll be presenting a case study on the topic psychosocial management of somatoform disorder and comorbid depression under the guidance of Dr. Sindhil M, PSW consultant CIP, and Mr. Atawla sir, PSW tutor CIP. The case is that of a patient who is 35 years old and married with chief complaints of reduced libido, inability to have sexual intercourse since adolescence, reduced mood, loss of interest in previously pleasurable activities, suicidal ideation, and reduced energy since 2017, irritability since 2020, and multiple bodily complaints since September 2024. In view of a detailed history and MSc, the patient was diagnosed with somatoform disorder, severe depression without psychotic symptoms, hypothyroidism, and cluster B traits with a query of vaginismus. So moving on to the introduction, As we all know, that somatoform disorders are a group of psychiatric disorders marked by multiple, recurrent, and medically unexplained physical symptoms that result in frequent healthcare visits and substantial functional impairment. When comorbid with depression, diagnostic clarity and early interventions become more challenging, requiring a comprehensive and integrated approach. Psychosocial interventions, particularly those addressing family dynamics, emotional regulation, unresolved past conflicts, and relational difficulties are important in improving patient outcome alongside pharmacological management. Methodology: we have adopted a biopsychosocial approach which included both pharmacological management and non-pharmacological management. In pharmacological management, after the establishment of TRAPO, a detailed the psychosocial assessment included a detailed family assessment using semi-structured interviews with the patient and the guardian, and structured tools like master family assessment device, marital quality scale, level of expressed emotions, family burden assessment, interview schedule, and couple assessments questionnaire. After the psychosocial formulation and diagnosis, a step care model was adopted for the interventions, where step care model is a healthcare model where the patients will be provided with the least intensive treatment and then gradually progresses to more intensive interventions. So the step care model, we started from psychoeducation, then to supportive psychotherapy, relaxation technique, activity scheduling, couple therapy, and family focused interventions to address dysfunctions in families such as boundary, communication, and dysfunctions in subsystems. Moving on to the result, the overall assessment revealed dysfunction across family dynamics, secondary supports, role, affective response, affective involvement, behavioral control, and general functioning of the family. And also, the marital quality of the couple was poor, and the satisfaction also was inadequate. Uh, the patient and the guardian were provided an 8 sessions of supportive psychotherapy and psychoeducation. The psychoeducation sessions were included about the providing awareness about the illness, its symptoms, and the comorbidity, and also body mind connection were also explained. uh, 8 sessions of supportive psychotherapy were provided, in which the trainee listened to the patient actively, validated the feelings, and ventilations of emotions were allowed. In relaxation techniques, the patient were taught about belly breathing, and also she was given unstructured activity scheduling, which was then increased to semi-structured activity scheduling. Then a 5 session of couple therapy was taken, uh, where with the patient partner sex education was taken. However, the patient was not ready for the intervention, so the couple therapy was withheld in between and will be carried out in follow-up sessions. Then, after a period of 1 month, the patient showed marked improvement in mood, somatic complaints, and daily functions. The interventions helped in improved insight into the illness, resolution of suicidal ideation, strengthened interpersonal relationship, better emotional regulation, and effective communication. Implications of the study are: the study highlights the need for integrated psychosocial and pharmacological care in management of somatoform disorder with comorbid depression. It emphasizes the importance of early psychosocial assessment using structured tools. Also, the study has an implication for the future studies on the long-term effectiveness of psychosocial interventions in somatoform disorder, and to explore patient and families' experience, emotional dynamics, and barrier to engage in psychosocial care. Moving on to conclusion, this study demonstrates that somatoform disorder with comorbid depression requires a comprehensive approach. Early identification of dysfunctional family dynamics and poor marital quality allowed for targeted, culturally relevant interventions that enhance the patient's insight, emotional regulation, and daily functioning. The case reinforces the critical role of psychiatric social work in facilitating holistic recovery and highlighted the value of multidisciplinary stepped care model in managing complex psychiatric conditions like somatoform disorder. Thank you. Hello.
Yes, Gitu. Thank you for presentation. Now the topic is open for the question, answer, and clarification. If anyone have any question, can ask.
Uh, Sir, I have a question.
Please go ahead.
Can you hear me, sir?
Yes, please.
Yeah, actually, this is Justin from CIP. Have you used any guideline for writing the case report?
I have written the abstract under the guidance of Atavla sir and Sendil sir.
No, there is a guideline. You have to follow the guideline for any.
Of the conference I have followed, sir.
No. I am not telling about the guideline. There's an international standard guideline for case reports. It's called CARE. So you
Okay,
have
sir.
to follow when next time when you write some case report,
Clarification
you
or
have to
question?
follow the guideline. Yeah.
Please
Okay,
just.
sir.
Okay, Gitu, you just tell me what are the relaxation in psychosocial intervention plan?
Sorry, sir, your voice is not audible.
What
It's break.
what you for relaxation?
A relaxation. I have provided belly breathing uh, for the patient for relaxation, breathing exercise.
Okay. Okay, Gitu, thank you
Okay, sir.
for your
Thank you, sir.
presentation. We have one more presentation from the same guideline. Malabika Das, are you there?
Yes, sir.
Yeah, Malabika Das is going to present reintegrating person with mental illness into the family, a psychiatric social work intervention. Please, Malabika, continue your presentation.
Yes, sir. Very good morning to all the respected members and others, respected all who present here. Uh, Today, I am presenting a case study regarding reintegration of.
Mute your phone or laptop. Malabika, mute your phone or laptop because your voice is echoing. Both are, I think, voices working.
Alvika, go ahead.
Today, I am presenting a case study regarding reintegration of a severely mentally ill patient. Along with me, there are two co-authors. I am Malvika Das, currently pursuing MPhil in psychiatric social work in CIP. Now I am presenting my case. Sharing. Sir. Introduction, severe mental illness. Sir, पूरा. Severe mental disorders are complex and affects a person's ability to think, feel, behave, and interact with others. It has been reported as one of the important public health problems in the world and leading to a disabling condition. Although psychotherapy is the mainstay of treatment, psychosocial interventions, especially focusing on regular follow-up drug adherence, family support, and vocational training help with the earlier recovery of patients with mental illnesses. This case study briefly demonstrates the psychosocial perspective of intervention for community reintegration of a female patient who has abandoned by her family and has been diagnosed with severe mental illness. This is socio-demographic data of the patient. Miss KK, she is 26 years old, studied up to primary level, unemployed, married but separated, Hindu, belonging, she is belonging to joint family, belonging to lower socio-economic status, and hailing from rural Bihar, Begusarai district. Clinical background of the case. Chief complaints: aggressive, abusive, and assaultive behavior, irrelevant talk, muttering, smiling, and gesturing to self, increased motor activity and wandering behavior, decreased sleep. These are since 4 years. Provisional diagnosis F25.0, schizoaffective disorder, manic type. Duration of hospitalization from 15th June 2024 to 8th February 2025. Barriers of reintegration. Barriers from family side. Lack of awareness regarding mental illness, family financial constraint, family history of unknown psychiatric illness and chronic physical illness of her mother, stigma towards mental illness. Now, focusing on barriers of stakeholders. Inadequate supervision from police station, no positive response from DLSA Ranchi, time constraint of the PSW training. Now, I am focusing on the process of reintegration. First of all, in our setup, telephonic contact made by the treating JR and family members not responded. Then, as per procedure, three letters of dispatch was discharge letters were dispatched from CRP, but they did not respond. They did not come. Again tried over phone to contact the family members, but they did not respond. Then from our psychiatric social department, we have contacted local police station Kake and also our legal aid cell, but we did not get any response from their side also. Then as a PSW trainee contacted local residential police station of the patient, and also the police personnel initially cooperated, and accordingly the concerned police station sent representative constable to twice to the patient's family, and then the family members did not come again. The trainee contacted with Sarpanch and member of the ward. Then family members assured and they will come, and finally they came and patient got discharged. This is intervention process. This is intervention psychosocial assessment, documented patient history and barriers to discharge, family stressing, hospital records, community networks, and local authorities, structured family counseling, 12 sessions addressing stigma, patient and family psychoeducation, and reintegration preparedness, multidisciplinary coordination, collaborated with psychiatrists, psychiatric nurses, and occupational therapists for clinical stability. Post-discharge plan, community reintegration plan, family support, follow-up telephonic sessions, local resources linked to local DMHP, follow-up, regular follow-ups has been maintained with psychiatrist and maintaining well. Strength of reintegration. Positive response from the Sarpanch, that is Panchayat Pradhan. Family attitude towards patients' mental illness has been improved. Reached out DMHP at Begusarai, Bihar for follow-up. This is outcome of my study. Psychosocial therapy and engaging the client helped her understand the link between stressors and illness, and she began to express herself more freely. The client was able to share her feelings and thoughts with her close ones. The client was able to reclaim her actual self and reconnect with family members, and the family was finally able to comprehend the condition, accept it, and continue to assist the client in the community. This is conclusion of my study. A case management approach which includes identification and assessing the client's needs, identifying and linking with community resources, coordination of services, client engagement, reintegration with the family, and continuation of the services will definitely result in a successful holistic rehabilitation services to address the issues. A comprehensive psychosocial assessment and intervention plan is very important to deliver the services and for reintegration of the homeless persons with the family and community, which is better explained by the concept of person in his environment. Thank you.
Okay, thank you, Malavika. You have presented very well. So further, if you have any question, anyone have any question, then please ask to Malavika, clarify. That's good, Malavika. No one have question. So I will go for a one question. So you just tell me when you are using 12 steps, yeah, 12 session with family, then why you are not saying this one is a family therapy? Why you given the name of some reintegration and all? Reintegrating person with mental illness. If you're using 12 session with family therapy, then this is a family therapy. Why this is the reintegration person of mental illness in a family?
Family therapy is very much
Malavika,
essential. Yes, sir.
you
Yeah,
you have given 12 steps.
sorry. Sir, just repeat.
Yes, you have given 12 sessions.
Yes,
You
sir.
have given 12 sessions for family therapy.
Sir, this was just
So this is the family therapy.
uh, it may in another word it may call family therapy because patient has mental illness and we have psychoeducated them to reduce the stigma and involve all the family members to this solve these issues.
Thank okay, thank you.
Okay, sir. Thank you so much, sir. Family therapy.
Chairpersons, you are not audible, any of you.
Hello, Naren sir, are
Yes.
you there?
Hello, Bhupendra. Yes.
So, sir, yes, sir, please, sir.
So,
We finished our presentation.
yeah, we have finished this session, and all the all the presentee have presented well. So I hope the all the paper is very important for as a mental health professional. Those who are working in mental health profession, and they have gained some knowledge regarding their presentation. So it was very indeed and very informative and very wonderful presentation. And the findings of each the paper and implication and conclusion were very much indeed and informative. So with this, I request to our another chairperson, please conclude the session.
Yeah, thank you so much, sir. Thank you so much, ISW. Thank you so much, Bhupendra sir. Thank you for the presenters, Sunila ma'am, Satyajit Bare, Swati, Dr. Sadab, Geetu, and Malavika. All the very best for you. And thank you so much. Sir, now over to Bhupendra sir.
Thank you, Dr. Naren Kumar Singh and Upen Singh for chairing the session and sparing your valuable time on this Sunday morning. You, both of the chairpersons and all the presenters, they have joined and presented their valuable contribution. ISPSW is thankful to all. Thank you so much.
Thank you, sir.
Okay, so with the thanking of this first session, we would move to our second session. That when we were preparing for conference guidelines and all, at that time I was given a task to plan some invited lectures and invited talk focusing on special populations and their needs. So while I was reviewing, I found very interesting thing which was existing but never came in my notice actually. So as per the last census, we have more than 9 crore elderly in our country, and that is means that the total number of elderly in India is only 16 countries are there, those who are having higher number of population, and others are having a lesser population than our elderlies. Another fact which I found that 2 lakh centurions, those who had touched their 100 years, they are in India. Another amazing point of the fact in my knowledge. Another fact which I must say, while I was designing and working on it, I was looking for elderly to chair this session. And unfortunately, no one agreed to accept that he is elderly. So for today's session, I think I have only one elderly who is the expert and who is the chairperson. Professor Hitesh Khurana. Sir is professor in psychiatry and experts in geriatric psychiatry. Uh, he is working as professor and serving his facilities over here even more than a decade in Institute of Mental Health, which was earlier known as Department of Psychiatry. Pandit B.D. Sharma, Postgraduate Institute of Medical College, Medical Sciences, Rohtak, Haryana. So, sir is here to enlighten some facts on the elderly, but before handing over to him, few things which compile me to plan such kind of event at the talk. Uh, Total around 48.2% elderly are females and 58% of them are divorced or widowed. So that is somewhere making them vulnerable for loneliness, for living alone. And it not ends. Yes, there is a fact that 70% of Indian populations, elder populations is residing in rural India. But despite that, another estimate says that 50 lakh people are living alone. These elderlies, they are living alone. Again, uh, this number is as much equal as Ireland or the New Zealand's total population. So I found that this population and the challenges faced by them need to be touched and addressed. So with this request, yes, sir, I agree that he is not elderly. Actually, I was just saying that I was trying to elderly, but those who were are those who are in elderly, those who were working and now retired, even they are not willing to accept that they are elderly. So I have means I don't have any option. So it is just a compiled condition to our resource person, and I'm just forcing him to accept it. Sir, Hitesh sir, over to you. Hitesh sir, are you with us? Ah, sir, we can't hear you, although I can see you.
Sir, you are not audible. Sir, I think laptop need a wire.
So,
Yes,
hello,
sir. Yes,
am
yes,
I
yes.
audible?
Yes, now you are.
Thank you very much, Dr. Bhupendra.
Thank you, sir.
And uh, I'm really thankful to the organizing team of the conference for giving me this opportunity to make a presentation in front of this August gathering. And I am really indebted for the same. And I am also thankful to Dr. Bhupendra for giving such a humorous, hilarious introduction of me. And while introducing myself, I think he had unconsciously overlooked that he has already played a role of elderly. That is introducing the topic, introducing the speaker. These all are the works of the chairpersons which he has done. So he has indirectly or unconsciously he is it is not me who is elderly, but he himself is elderly. Well, anyway, the roles should always be interchangeable, and I accept my role of a young person because just adding uh, age is just adding number of years to one's life profile and nothing more than that. And it is up to the person himself to consider himself young or elderly. Elderly people, younger people are having energy, enthusiasm, and the elderly people are wiser and they can guide the younger people. So both have to act in unison with each other for any kind of discipline, for any kind of project, wherever the success is required. And he has given me a very interesting topic, that is the loneliness, elderly, and the mental health. And indeed, this topic is very close to my heart, and I would try my best to give full justice to this particular topic. And am I allowed to share my slides?
Yes, sir, please.
Okay, yes. Now, my another very important question to you all. Are my slides visible?
Yes, it is
Uh, and
in the
I'll be
editing
asking,
mode.
I'll be asking my second question also very soon. Ki, are my slides moving?
Yes.
Oh, then it is fine. And so this is a topic which has been allotted to me, the loneliness, isolation, and mental health of the older adults. And while allotting this particular topic, again, I think Dr. Bhupendra had unconsciously put the word adults with the older, and thinking that the elders are always adults and they don't age too much that they can't do anything. And thank you, Dr. Bhupendra, for having so much respect for the elderly persons. I'm really grateful to you. And if we talk of the elderly, as Dr. Bhupendra has already introduced, we always think of the isolation, loneliness as one of the key risk factor to their health. And what loneliness is, and I came across a few. First of all, I came just search the what the common people think, or the common people have an idea about the elderly persons or the problems of the elderly. And I was just scrolling through the newspaper and I came across many recent news about the elderly people, loneliness and depression. And indeed, I came across many such news, and it was found that it is really a rampant problem. It cannot be ignored. I came across this particular news clipping which says that loneliness is pushing a Chandigarh elderly into the depression. And indeed, they say what has been the reason, and the reason has again been the youth. that they are migrating to different places, whether in India, within India, or they are going out of the India for their own jobs and the other career prospects. Indeed, both are very essential, and we cannot say them no and restrict themselves to their career within their city where they have lesser prospects. And during COVID also, there had been everybody has experienced loneliness, but these were the elderly who had suffered most from the loneliness because they were really isolated, considering themselves at the risk of developing COVID. So even the family members were avoiding, but they devised their own way of the WhatsApp chat, and they started connecting and with their friend circle and with the family members, and ultimately they were able to do it quite successfully. But this is not the loneliness and the neglect. This also leads to a lot of abuse and a lot of other problems also. And this particular survey says that about 20% of the Chandigarh population is elderly are living alone, but and they are being abused. But this figure can be much more than that also. And once they are abused, many times they feel like leaving the home and living in the old age homes, and many by choice, and many because of their own problems. And indeed, there also they really feel happy, but they again miss the company of their family members. And that's what the elderly are actually the psyche of elderly is. They are, even if they are old, even if they can't make any kind of physical contribution, they can't run here and there, but they always miss the family, and they always think of the well-being of their family. And this is the same story has come from the 102-year-old citizen from the city of Chandigarh. And keeping this news into consideration, about 20% are being abused, and there is a large chunk of elderly population, and this chunk proportion is becoming increasing every more and more every day. Is it that we are really overlooking an epidemic of a problems which is going to be unmanageable in the coming years? Even 20% population of being abused, this is really too much. Why it is too much? Because if we see that the most of the elderly, the most of the population of the world is living in the India or in the Asian countries, and among those, therefore, the most of the elderlies are also living in these countries only. And India having the second biggest population, at probably maybe the number one also, most of the elderly and the abused and the neglected population is living in India. So it is a lot of a burden on the mental health professional and the social work professionals, that how to take care of this problem. And indeed, and unfortunately, we are really not prepared for that. And the neglect of the elderly, whether in the families or whether at the policy level, this continues. We are making a very good policies, but what ultimately is reaching the elderly persons is just the 3,000 rupees in Haryana, and maybe that even the lesser than that in the other other states. So elderly are really suffering, and they really have to do something on their own. They have always to be somewhat innovative in overcoming their problems. So logins, WhatsApp, chats, this is making them help in avoiding the loneliness. And indeed, as Dr. Bhupendra had said in while introducing the topic, that almost half of the elderly who are suffering, who are lonely, are the ladies, even more than that. This survey is very old. I'll say very old in comparison with newer developments, because this has taken place in the 2017, and now it is 2024, almost 7 years ago, and the number would be somewhat different than what is being presented over here. And oh, it is a 65%, Dr. Bhupendra. It is not a small proportion at all. In fact, the youth is becoming a very small proportion in that. And why these elderlies are becoming lonely? Again, this is because of the tech among youth. Everybody is having a mobile phone. Everybody is having a laptop, and they are busy with that. Even if two persons are there in the family, instead of talking to each other, they are preferring it easier to spend the time on the news, in the chats or in the and I came across this particular couplet from an Urdu unknown poet, and indeed this explains what all the loneliness is. जम घटा सितारों का चांद अकेला था, दोस्ती की महफिल में दोस्त अकेला था, पूछता रहा सितारों से कि महफिल की खुशी मेरे हिस्से क्यों नहीं आई. There are so many people around, but the one person is becoming isolated either because of the personal reasons or because of the social reasons also. And because of there is a emotional distance, there is a networking distance, and which is bringing some sort of sadness and unhappiness among the elderly, and they are unable to enjoy the company, whether even if they are among their family members or with their friends. So loneliness, if we see, this is almost a universal phenomenon. Okay, if we see the aging and this particular group map, you can see that where it is showing that especially the red and the yellow portion are really alarming, and these are mostly concentrated towards the in the Asian countries, and where the and somewhat in the American countries, where the proportion of the elderly is really very big, and India is still in the green, but keeping in view the proportion or the population load that India is suffering, is having, this particular proportion is also making the population of any other developing country. And if we ask the elderly people, 79% are feeling occasional loneling. Occasional loneling, of course, everybody feels, but 15% they are feeling lonely all the time. That is a quite serious thing. And only 6% felt that okay, in whatever circumstances they are living, it is okay. And keeping this thing into consideration, what happened that seeing this as a developing pandemic, UK and the Japan government made a separate provision or made a particular policy that instead of, besides having the other kinds of ministries, Ministry of Social Welfare, the Ministry of Sports, or the Child and Women Welfare, they should have a society of uh, they should have a ministry of loneliness also. Okay, how to combat loneliness. And indeed, having this kind of ministry is really not a happy development, but somehow we have to develop how to manage our elderly person. And so for this we have to make some kind of policies issues also. And if we see that how many of those are really lonely, and nearly about 20 to, if 20 to 25% from India and from the other parts also, loneliness is widely reported. It is not just from the any other developing country. You can say it is a global kind of a process. And all those countries which are appearing white would be having the yellow or the red green color after about 10 or 5 or 10 years. I am 100% sure of it. Keeping in view in India about the situation is that in India also, when the survey was carried, this is a this particular data is from a very famous study, which is a longitudinal aging study of India, which says that almost from 7% to almost 20% of people in the different state are lonely. And from the Andaman Nicobar, the maximum loneliness, 29% has been reported. And it is really alarming with that key how we are really progressing. Or if it is the really what is called as development, then a lot of things are to be seen, that we are much lagging behind the development if we are not able to reach a large proportion of our people. Often we are, if we see the research literature, we often come across three different terms. One is the loneliness, other is the social isolation, and the other is the what we call as solitude also. Solitude, of course, there is not much of the controversy, but loneliness and the isolation are often very confused term. Loneliness, when we talk, if you see all these definitions, three definitions are written here from the different authors, and it is mostly a kind of subjective feeling that even it just as the moon is feeling lonely among the stars, lot of people are there, but still a person can feel lonely, the person can feel ignored, the person can feel helpless, and it is a largely a subjective feeling. But when a person is unable to reach the other people, unable to develop the network, and it is it may be because of some kind of disability, it may be because of some kind of disastrous situations like floods or anything equally disasters, or maybe that the person is having some kind of illness, person is having some kind of hearing impairment. This will develop a disconnectedness from the society, which is having some kind of physical means, which is because of some kind of physical reasons. And these, when these kinds of reasons are there, which we can see very easily, these are considered as the isolation. So isolation is something really objective, which we can see as a lack of networking or lack of the effective networks. But loneliness, on the other hand, is the completely an individual phenomena, or completely a person's own feelings of being left alone, or not able to enjoy the company of others, where person is having the desire to enjoy. Loneliness, this can be of different types. And just as we say that every stress is a eustress, or it can be distress, in similar with the loneliness, if we consider it as equivalent to stress, it can be loneliness also, and it can be the disloneliness also. And just remove the L from loneliness, it becomes loneliness. And if the person is able to stay alone, and the person is able to enjoy the isolate this kind of isolation, many times this is equivalent to the solitude, and this is enjoyable. But when the loneliness is not really so, and many times it is transient loneliness, of course we experience almost every day. Okay, it is supposing we are living in a family, and the wife has to go away, supposing going to the mother-in-law, will be feeling lonely, but we'll be able to enjoy this. And so this is a kind of you stress, or the you loneliness, if I have to develop some kind of neologism. So this kind of thing where we are in touch with the others, and we are having a very healthy relationship, but transiently it is that those kinds of relationships are not available to us, and we have a longing for that. That is a transient, and it will just come and go. Situational loneliness comes frequently in our lives, and this is also essential for our development. That these kinds of loneliness is there at the different phases of life. And these phases can be uh, a student just passing 12th class, and now the person has to go to the hostel, and this is a sort of situational loneliness. And from hostel, the person is going to the other country or city for job. It is again a situational kind of loneliness. But if the person is not able to establish a good social bonding over there, or the person is still missing his home, the person is feeling homesick for significant time, as the books have described, at least for 2 years, this becomes the chronic kind of loneliness, and this is really a pathological state, and this needs to be overcome, and this needs to be taken equivalent to a disease or a disorder, in just not just as a risk factor. It can be a trait, and that trait also, the many kind of psychologists say that those who feel loneliness are having some kind of specific kind of personality trait, and because of which they feel lonely. They are introvert, and they are not having the enough kind of social skills, because of which they are not able to exploit or get benefit of the social network which is there around. State in the transient kind of situations or the situation loneliness, of course, these are the state kind of things which we can overcome very easily. Intimate relational and the collective loneliness are something like the primary, secondary, and the tertiary support, which the postgraduate students often talk about. And in case we are missing someone, we do not find comfortable, or some loved one has disappeared because of death or because of migration, wife, husband, or children, and we are not able to share our feelings, it may be called as the intimate kind of loneliness. But on the other hand, if we are having the lack of friends, of course, with whom we can share our belongingness but not everything, and it is a kind of the relational loneliness. And the collective loneliness again comes from the feeling, a group feeling. If we are working in, let's say, in some other country, US, or even if we are working in South, or there's some South Indian comes to the North and they found a person from their own community, they really feel happy and satisfied. Ki, okay, or you are from this particular place. Even the strangers would be interested in becoming would feel like interacting with the person whom they had never seen, but it is just because they share something common, they share the common roots, because of which they are like that. Okay, we Indians, when we are living in New York or we are living in UK, and we feel happy by seeing some Indian over there, that is because of the collective loneliness. And there can be a different kinds of advantages and the different kinds of disadvantages because of all this. Emotional loneliness is that kind of, again, an internal feeling only, where the person is having sufficient social resources around, but the person is okay, yeah, maza nahi aa raha. Okay, I don't feel like talking or interacting with these people, and these people are not really helpful. It can be in either way, either self reproach or जो है कि being critical of others. This will constitute the emotional kind of loneliness. And the social loneliness is really when our physical relationships are not there, we are really socially isolated, and we feel like talking to someone, and it is, this situation is completely unlike a schizoid person, and completely unlike a person who is thinking of, or who is just wishing for solitude. And so there can be other kinds of classifications also, but these four kinds of classification I came across in the various literatures, and these all have been summarized by Grover in his article which published in 2022. Social isolation, I think by now you are very clear about it, and it is an objective phenomena where the person or the onlooker or the health worker can also see, yes, the person is now socially isolated because nobody is coming to meet him, and the person is not able to do a lot of things just because of he's having no company. And so this is a physical phenomenon. But if you see the research is largely confused about the social isolation and the loneliness. And what in research you will be finding is that whenever loneliness is taken, this is almost always with social isolation, and the vice versa. Indeed, the research shows that the outcome of social isolation and loneliness, this is more or less same kind of outcome is there, and the methods of managing may also be the similar one, with slight differences. If we say that why do people feel lonely, loneliness can be felt by men think either they are having some kind of traits that they always have a low esteem, and they are always estimating their capabilities lesser and lesser, because of they feel that yes, I am incapable and I should not, maybe that people won't like me, but क्या किया जा सकता है, I am not capable of that, and that kind of thing may also lead them to seclude themselves from the people around, even in a group. Or they may also see that other people are quite selfish, and the other people are quite unreliable, and so they do not support, and we should not be taking care, we should not interact with others, whereas they really feel a need of interacting with others. And this is again causing a kind of loneliness. And is the social hunger. So a feeling of social hunger is very essential for the purpose of feeling lonely. And it has also been seen that while reporting loneliness, there is a bias. And if the social hunger desire to make connections, this is more, even if they are interacting with people around, they will always complain of having a lesser number of friends, or the lesser number of people who take care of them, or the lesser number of people whom they can share their feelings with them. So this kind of thing is also very prominent in the profile of the lonely people. And all these things, you can see that these do not require any kind of uh, group kind of intervention or the social kind of interventions, but the psychotherapies would be required for these kinds of things. And if we come to the social aspects, they are having the lesser of the social skills, and they are not able to affiliate with the different kinds of groups to which they belongs to. And they are also lacking the assertiveness, and they won't be able to take any kind of leadership, or they won't be able to be willing to take some kind of responsibility, and because of which again they'll be slugging behind, and they'll be complaining of the different kinds of uh, uh, they'll be landing in the different kinds of the health issues. And ultimately what happens, and these kinds of person either develop the active solitude, they take up different kinds of interest, maybe that they would be taking, so they would be reading about astrology, or they would be reading about philosophy, and they would be reading novels, or in this way they'll be doing all those kinds of activity which a solitary person can do, and they don't need any kind of help. Or in order to take care, especially it has been seen, and mostly the ladies are criticized for that, but all are all are equal in that aspects also. They'll be just spending a lot of money on useless kind of shopping, or they would be making a lot of contacts online, or they'll be just feeling sad, and they will be sitting idle in their room, and they say yes, the life is becoming hell, and the life is becoming useless. So the depression again can have some kind of roots in the loneliness which comes from their lack of the social skills. So in this particular study, this message is there which need to be taken care by all the social work professionals. And the development of loneliness, it is also very similar to what Elizabeth Kubler-Ross has said initially. There is a pain, and it's awareness. There has been some kind of event, and it is really felt painful, and it would be completely denied, and the person will start feeling comfortable. But soon it would be denied, would be soon broken, and there would be an alarm and the realization, the person is becoming alert of those, and then the person is just bargaining about that, and that they are searching for the cause and the self-doubt, and what can be changed and what it can be there, and ultimately the person would be accepting and coming for any kind of help. But these kinds of stances where the person is coming for help for the loneliness, these are very rare, but they'll be coping with the loneliness by themselves only. And this particular slide tells you about the different kinds of the characteristics of the loneliness, solitude, and social isolation. And depression, of course, I have just put here for the purpose of completeness, but otherwise, it is not required for this particular discussion. And the first that the mental and the physical state and the company and the reasons and the consequences, these are the most important differentiating features, that it is just as a loneliness is subjective state, and it is the social isolation is the negative objective or the physical state. And the reasons of the lack of satisfaction, I can be satisfied with the small amount of money, but some person may not be able to satisfy with the huge bank balance. And the same kind of thing is over here. Someone will be satisfied two or three friends, and one is not satisfied with many friends also. And whereas in the social isolation, some kind of disability, unemployment, in being in debt, having some kind of adverse background, something like that, a criminal background, health issues, these may impair the person's contact with the others, and it will create social isolation. And the consequences are almost, and all consequences are adverse consequences. If we summarize all these features, and it has how the research has taken all these things, we can take that there are the lesser focus on the personal factors, on the or the individual characteristics which are shown in green, and large focus is on the environmental and the on the social and the relationship dynamics. इसके ऊपर काफी काम है, but the environmental factors are again very less. But if you see the literature, see the Google Scholar or even PubMed, you will be finding lakhs of references on loneliness. Work is not less, but perhaps it has become some kind of stereotype that the few things are being researched more and more, and the others are getting ignored and ignored. And so this particular slide I find useful in case someone has to plan some particular research or some kind of plan project or thesis. I think the factors which are listed in green, and these factors or the interaction of these factors can be really considered very helpful for the future kind of research projects on the loneliness in relation to mental health and the other disorders. Epidemiology, Dr. Bhupendra had already specified something about that the females are more likely to report loneliness. Of course, indeed, it is true. And age is having a sort of U-shaped curve with the either in very youth or in the elderly, the loneliness is more. And we are talking about the elderly only. And one particular example that whenever the youth has grown up and they have to move out for their job or for their nowadays even for studies, emptiness syndrome all elderlies have to encounter, and which will give them a feeling of isolation as well as loneliness. And it has been seen that those who have the poor quality of contacts and those who have poor competence, they are not able to make any kind of good contribution towards their friend circle or in the family or in the society. They are suffering more in the low socioeconomic status, chronic medical illnesses, because many of the youth are taking it as a burden and something which is missed in it, but it is very important nowadays, the use of technology. This has really created a lot of impact on the social health of elderly, and of course on everybody's health, and because and most of the people are feeling lonely because of the technology only nowadays. Gender differences, these are really very interesting, that older women were less likely, older men are less likely to state that when they are lonely, even if they are having the same kinds of scores on different measures. They would, if they are interviewed, they'll be saying that, okay, yeah, we are not very lonely or not separately. Again, it is because of the social desirability or some kind of the cultural stereotypes that men are not expected to report their distress in comparison with the women. And perhaps this is the reason that women are more open to report about the loneliness also. And it can also be seen from those which are the red lettered sentences over here, that even the older women who are cohabiting, they are also reporting, less lonely. And but those who are older women who are never married, they are also reporting more loneliness. So it is both ways that it would be reported more among the by the females in comparison with the with the men. And this particular reporting tendency has also to be cared for a lot when we are making any kind of research. And this thing can be sorted out only through the mixed method of research, where we are using scales, but we are also taking help of some kind of qualitative data to confirm those findings. And this particular study, which is from India itself, and from the longitudinal aging study of India, it also highlights almost the similar things. And it is a interesting thing in it is that it is not differentiating between the loneliness and the social isolation at all. 30.4% elderly are frequently reporting loneliness. But what is that? Not being in marital union, that is again a social isolation, in a way social isolation. Having two or more chronic illnesses make whether they are living in company or they are not able to move around, having difficulty in performing the instrumental activities and the activities of daily life, being non-involved, and having the small social networks are reporting the higher kinds of loneliness. And here, of course, if you see the data of this particular study, which is available to all, but just by logging into the particular website, it shows that there is a social isolation among elderlies also. But social isolation and the loneliness, these are mixed together when the results of this particular study are compiled and interpreted. And indeed, the same thing is happening in most of the studies. Almost 80 to 90% of the studies are taking social isolation equal to loneliness, equal to a risk factor for a mental illness. And the tools which we see tools, of course, these are entirely different. And we can see that if we take care of that, we can really separate where the social isolation is there and where the loneliness starts. If we see at the tools on the which are there on the left side of the slides, the Wagner Sports Network, Litwin's network type works. What these are just examining the structure of sports, and not the structure is something very objective. This can be verified, and the structure, if this is intact, it means that we are having the intact support there. But diagonally opposite to it is the perception only, the perception of the feelings, and the extreme diagonally down to right is the loneliness. And the loneliness and the social isolation, these really can be identified, differentiated with the help of available tools. That only thing is we require a bit of scientific vigor whenever we are making a such study on the isolation and the loneliness. And again, I consider this as a very important kind of study. I'll share these slides with the organizers, and you all can have this from them. And these are the different kinds of tools which are available for the for loneliness. And we have the small tools also, just having the 3 items, and these are also found that having a good specificity and sensitivity to almost those equivalent to which are of the 11 or the 20 items. So whichever tool the person wish to use, depending upon the culture, depending upon the kind of study, one can choose the still. And Hindi translations also of few of the scales are available, like the Ookla 3 item and 20 item versions. These are available in Hindi also. The consequences of loneliness. Just now, it is very interesting to see that just now what we have seen, that we have seen that loneliness is just the psychological and the social phenomena. But whenever psychological or the social phenomena is good, there is a release of endorphin, there is release of dopamine. Whenever we are meeting friend, we are feeling happy, dopamine is released, we are thrilled, feeling happy. And when we are sad, it increases the cholesterol level, platelets aggregation, it impairs immune functioning, makes autonomic instabilities, and we feel यार क्या करना, थक गए हैं. It leads to lack of physical activity, खाने का मन नहीं करता है, we are not able to sleep, and we think of the different kinds of maladaptive coping like smoking and alcohol use, and there can be many others also. So there is an interaction between the psychological, sociological factors and biological factors. So ultimately, so isolation and loneliness, this becomes an biopsychosocial issue which is equivalent to a disease. And indeed, if we see the diagram on the right side, loneliness, if there is start from anywhere. If we are having poor self-esteem, it will lead to social isolation. It will give us a feeling of loneliness. Again, it will set up a vicious circle. Start from anywhere, and it will give a feeling, and it can then provoke any kind of biological thing, and it may lead to different kinds of cardiovascular phenomena, and it can lead to different kinds of the psychological phenomena, depression, anxiety. And indeed, when the depression, anxiety, or these kinds of illnesses are there, we know that it can lead to the cardiovascular diseases and stroke also. And when the stroke or the cardiovascular diseases are there, this can lead to the depression, anxiety, even dementia also. And so this makes a sort of complete network. And most interesting thing is that out of all these things, what is the easiest to manage is the loneliness, is the social isolation. If we are able to take care of these two things, we are able to avoid a lot of physical illnesses, and we are able to avoid a lot of mental illnesses also equally. So the prevention is always better than cure, and this particular slide really highlights. If we imagine the cost of preventing isolation and low self-esteem, this is much less than the cost of any kind treatment of any kind of cardiovascular disease or depression. Indeed, it has depression is nowadays considered as the most disabling kind of condition, but loneliness, it yet has to find its place in the diagnostic systems. Is loneliness heritable? Yes, it is. If this is a trait, every behavior is heritable. And so the loneliness also. Does the environmental factors also impact loneliness and isolation? Yes, the environmental factors also impact. And the family dynamics, do they play just like any kind of mental disorder or condition? The family dynamics also play a role in determining the social isolation. It is not uncommon to see that in some particular family, a particular person, especially elderly, is completely isolated, staying in a particular a room where nobody is going, but the all other persons are interacting while sitting in different rooms. And so loneliness, again, I would like to emphasize, this is not just a kind of social concept, it is a biopsychosocial concept, which is a particular kind of disease. And just as for a disease, we do the epidemiological survey, and we find that percentage with loneliness also can be qualified, and this can be quantified. And epidemiological, this is really at a rampant rate, even if it is from the 30% or the 61%, somewhere 100% have also been reported. This is really a public health problem at that time. It is having some kind of signs and symptoms also, so it is having a clinical description also. Laboratory studies, if we go to different kinds of scale, loneliness scale or the isolation scale, we can see from those, and we can also see from the biological measures that these kinds of isolation are leading to some kind of biological changes in the person's body. Again, that this is there. And we can also delimit from the other disease, whether these are the physical diseases or whether these are the psychological diseases, anxiety, depression, we can delimit from those also. And if we follow up those who are having the isolation and who are having the loneliness, they are really will be finding that it is leading to some kind of complications if these are not treated. But when the some kind of intervention is made, it really leads to a physical and emotional and the social well-being. Family studies also suggest the loneliness runs into the family. So the Robbins and Goose criteria, the Robbins in 1970 say that if a particular entity is able, we can describe in all these five categories, then that thing should be labeled as disease. And indeed, the loneliness is fulfilling all these criteria. And we need, only thing is that we need to study this particular thing as a disease, and we have to make some kind of recommendations that it should be included in the some kind of our existing or in the new coming or classification the nosological systems also. And so different studies here, this one particular study you can see over here. This is a meta-analysis. In fact, there are about 3 or 4 meta-analyses or the systematic reviews almost every year on the loneliness. There are so many studies. What is noteworthy in this particular thing is that the loneliness and isolation, these are not differentiated, these are taken together, and most of the studies are doing things. And of course, the prevalence is quite high, that it is about 89% among those who are 89 to 69%, those who are ill and those who are isolated. Loneliness, these are going almost simultaneously, and it is having the physical, mental, and the social consequences also. And few studies have found the gender differences, and few studies have not. And again, I will say it again depends upon the development or the gender equality norms in those particular countries from where these studies have been reported. Uh, and Again, this study, which has been reported from India, and this again suggests that the findings say that yes, the social isolation and loneliness among elderly, these indeed exist, and these should be taken care while making some kind of interventions. Although they had taken the Logan social network scale and the Ookla scale also, but again, the results are not differentiating between the social isolation and the loneliness, and there might be some subtle differences, but the outcome is considered almost equal. And what has been often emphasized, how the loneliness and the isolation can be improved, as we have seen from the earlier author's work, that if we are improving the person's social skill, it can reduce the social isolation, and it can reduce the loneliness also. With the help of electronic gadgets, if we can make our elderly comfortable with the use of these gadgets, again, they would be able to have some kind of advantage of this. Social support enhancement, these look really very good at the policy levels, but we have always to act at the micro levels, because if we see, we are really very good at making policies, and our different kinds of the mental health program, whether we talk of national mental health program, district mental health program, or NPOP, or the policy for the older people, all these really good look very good. But how far we have been able to reach the elderly with the help of this policy, there is a big question mark on it, and again the people are complaining. But if we come to the micro level, what we can do ourselves and what those elderly can do, just like a befriending the people, having some pet, and have developing some kind of hobby, becoming friendly with the technology, And these kinds of things are really helpful. Being a medical practitioner, of course, pharmacological interventions, these really become a focus of my attention. So these are indeed helpful, but these are helpful only in the extreme situations when the depression, anxiety symptoms are developing, and initially, which we have to do with just with a small amount, cost amount. This is the main kind of therapy which we can do. This is again a meta-analysis, and the meta-analysis says that these kinds of therapies are really helpful, though their effect size may be of the group therapies or maybe really very small. And this small group effect size may be because of the lot of heterogeneity. We can see that here in the group 1, I square is 43.4%, and the other group it is 63.1. And these are really kind of heterogeneous studies. And but indeed, there are few studies which are favoring the better outcome also with the interventions. And we should always take those studies as the model for planning further studies. And internet-based studies, these are the individual interactions. These really have not been found very helpful. But again, if we see the heterogeneity factors, which is ranging from 35 to 70%, and so there is a lot of poor quality of research existing on the isolation and the loneliness, which we need to take care of in our further research. And this research again, which is carried out from somewhere in the West, this is again a sort of review only. And uh, and this again says that yes, if the therapies are developed for multiple objectives, these can be really effective in comparison with those which are developed for the single objectives. And in conclusion, what I wish to say is that the loneliness, social isolation are widely prevalent conditions. Even now, this is unmanageable, and in the coming time, this is really becoming a sort of a nightmare for us. Better start working right now on these. And social isolation and loneliness, these are different entities, but somehow these are dealt as inseparable in the research, and these do not differentiate from each other. And these are akin to a disease. It is having an etiology, it is having clinical features also, and it is having own course complications, and this can be cured, or this can be treated also. And if there is any existing physical, social, or the mental health condition, it will have an adverse impact on that as a risk factor, as it happens with the other diseases like hypertension and the diabetes also, which become a risk factor for the depression, anxiety, and vice versa also. And it is indeed preventable. We need to have a policy. We need to have work in our clinics, but indeed, our responsibility is that we should act at least at the micro level. When the patient is coming to us, we should address the issues related to the loneliness and the isolation also, which work better than the policies most of the times, as we see. This is from the Mother Teresa's quote that the greatest disease in the West today is not TB or the leprosy. It is being unwanted, unloved, uncared. And we can cure physical diseases with medicine, but the only cure for loneliness, depression, hopelessness is love. And we all are young Dr. Bhupendra, and let's start loving each other, and we'll prevent loneliness and feel comfortable in the society. Thank you very much.
Thank you, sir. So, thank you so much for this wonderful talk. And just before moving any further, I would like to touch a quote that was very famous, given by Vincent King. He says that knowledge is power, power is wisdom, and wisdom is understanding. So considering that your all information presented and delivered over here, that will lead us and strengthen us to manage such kind of challenges. Now I have a question in my mind, but before coming to my question, I would like to read a comment which I don't want to read, but I have to. Ravi sir has mentioned that about the presenter, speaker, Hitesh sir. He is not elderly, he is working with elderly. I'm afraid so he is working with me, and I don't want to say that he is working with elderly, but
Sir,
have
we
to say
are,
yes, he is.
sir, we are working togetherly for elderly. I would like to modify it.
Uh, So just the question, sir, what I have in my mind, although we are running a bit late from our schedule from your starting itself, not it because of you. So that only one question, what I have in my mind is that how integrating religion, spirituality can improve the well-being or can contribute something in this regard of the loneliness and specifically that isolation, mental health issues of the older adults.
Yes, okay, this is indeed a very good question, Dr. Bhupendra, that religious feelings, spirituality, these do take care of loneliness. Okay, what does the religiosity and the spirituality does? It just transforms a person's thinking or the transforms the person's cognition. And it takes the person from loneliness to what we call as solitude. Now, the solitude is something a positive. In solitude, there are, if the studies are conducted on the solitude, and they do suggest those solitude people who practice solitude, they have a better kind of mental well-being, objectively as well as subjectively. They don't hate people, they don't avoid people, and they don't long for meeting people, but they feel comfortable with whatever they have. And in this way, religious beliefs or the spirituality, this gives them a support to modify their approach towards the outer world. In this way, they are able to feel better.
Actually,
Thank you, sir.
Professor, you have said very well. There is a saying, Sanskrit actually, Tamil also is there. Inidu ekandam inidu. I think you understand the word ekandam. Solitude. The better word here is ekandam. Are
Yes,
you
yes, Ekant,
the
okay,
next
I agree.
when we are in solitude or ekanda, we are there with the divine. So that is.
And one more thing, sir, I would like to suggest over here that in case you come across those persons who like solitude, it is not really that they are just liking ekantam. It is not really like that, but it is something more than that. They want to connect themselves with the nature. If you see that most of people, where do they go for solitude? They go to the Himalayas or they go to the mountains for some isolated places which are full of natural calmity and contentedness. And that kind of feeling of that gives them a feeling of connectedness with the universe itself. And so solitude is having a different dimension also.
Sir, that both of your discussion, although I was not intent to ask any further questions, but another question came in mind that loneliness, while often perceived as a negative experience, but can loneliness be reframed in the light of a spiritual or in the spiritual lens as an opportunity? Although we are considering loneliness is a negative perspective, but when we are perceiving or reframing this loneliness in the eyes of religion or in the eyes of spirituality, can we consider it as a strength?
Uh, yes, I think we can. And we should always think of doing like that because this is something very easy. In this, what we'll be doing exactly is we'll be validating the person's feelings also. Loneliness is a very subjective, distressed feeling, and we would be channelizing it towards the person's betterment also. Okay, if you are feeling lonely, you don't have anyone to talk or you don't have anyone to interact, there is another way. Nature is offering you a better way of interacting. Just if you will be interacting with the nature, you will be feeling much better than that. So in that way, the situation will remain the same. The person's coping abilities, those would improve, and ultimately the person's well-being also. This is what I feel.
Right, sir.
Sir,
Thank you so much, sir.
can,
Yes, please.
sir, can the loneliness can increase self-awareness, emotional regulation, and also creativity. Some creative individuals try to separate themselves to the community, to the family member, and they create something new. So loneliness in the positive way can do.
Again, very interesting question, sir. Uh, I won't say no to it because I have seen that many artists and many persons, even those who are suffering from mental disorders, they have done wonders in the world of creativity. If we talk of different story writers and different poets, even the John Keats and P.B. Shelley and other, even the Shiv Kumar Batalvi, they had been very lonely persons, and who doesn't know them? So they can do it. Only thing is कि they have to devise some kind of way how to cope up with that. कि as कि some people develop जो कि isolation. Those who are lonely, they become emotionally isolated and they start doing some kind of solitary activities. And those act as the coping methods, and ultimately they turn out to be creative. And but what I feel is that many times the people tend to link creativity and the mental illness also together, but it may perhaps not be true. It is perhaps that those people who excel to that level, they are having isolation because they have a lot of interest, they have a lot of desire to connect with people, and they have a lot of creative potential also. And so they use their creative potential and they start interacting with the society. So this, it can be the both way. They have the both kind of characteristics, the problems as well as creativity. But nevertheless, the creativity is a very good way of intervening with the loneliness solution.
And one more, sir, the clarification, because in recent trend there is the prevalence rate of loneliness, but nowadays the cell phone, internet, and everything, social media is there. So can this thing also reduce the loneliness of the elderly, yeah, older
This has a
adults?
potential. कि many studies are there कि which say that कि those who are using some kind of internet or they are using social media, they are feeling less lonely, and they have been able to create their own online groups also, and they are able to spend their time quite usefully with happily without having any kind of distressful feelings. And these are usually, but the problem with our elderly is because of their low literacy level, they are not very, it is not very easy for them to use these kinds of electronic gadgets. But
Yes.
I'll say that if they are left to these gadgets and some little training is given to them, perhaps they will also get used to it and they will be able to do that. After all, I'll be asking ki, how many of us have done some kind of certificate or diploma course in using mobile phones? We are using this the knowledge of mobile phones, using it much better than the knowledge of our textbooks and whatever teachers have taught. And so the elderly and those who are lesser educated, they can also be taught about these gadgets very easy.
Very easy.
Thank you,
You
sir.
so much,
I'm
sir.
afraid I have to control conversation over here, although I know that this topic is very interesting. And I, in my own mind, have a lot of thoughts, so I'm presuming that others also having. But considering the time, I have to stop over here. Thank you so much, Hitesh, sir, for your wonderful deliveries and the knowledge, delivering the knowledge and empowering us with the understanding in regard to our older adults. Thank you so much, sir.
Thank you very much, sir, and thank you very much, all our August audience, for listening to me very patiently and carefully. Thank you, everyone.